speaker. Again, that's Apoorva Ayachit. She's a consultant in Nimam Joshi Hospital from Mobley. And she's going to talk about her experience using the new kid in the blog. That's the Ingenuity 3D digital visualization, digital DAB, so otherwise they call it, digitally assisted vitrectomy surgery. Yeah, over to you, Dr. Apoorva.
Thank you so much, sir. I'm very excited and actually honored to be on this panel with all of you, and it's really a pleasure to share this journey of using 3D visualization for VR surgeries. So we know how evolution of retinal surgeries have happened over the years. There was ignipuncture, diathermy at the scleral bed. Later, cryo came in, and then there was this all-in-one VISC, the vitreous infusion, suction, and cutter. So, okay, yeah. So, patients in the past used to be bilaterally patched and given bed rest for almost 2 weeks, and nobody used to complain. That was the norm. Then we had these Mashimer lenses, and then the Lander lenses came in. This is a very old video of my mentor, Dr. Guru Prasad, who's using a Lander's lens. And this was considered kind of out of the world view for that time or that point in time. Then, of course, we got the contact lenses, the handheld ones, and then we got this integrated biome systems for wide angle visualization. And then just this kind of giant wow factor entered into our VR surgical circles, where the Ingenuity just came in, and it was in 2016 when it was introduced. And in 2017, I believe they improved the latency issues a bit, especially for the anterior segment. I remember, since we were one of the first users of Ingenuity in the country, we remember that we almost could not use it for anterior segment surgeries because of such a lag. And then they started improving the lags. For the posterior segment surgeries, we've never experienced any lag. It has always been wonderful. And then in 2018, the latter part, real time surgical parameter viewing was also integrated. And then 2019, data fusion softwares for additional system controls were introduced. And then, of course, in 2020, it was integrated with Centurion for anterior segment. So this has been our setup more or less for the last 3.5, 4 years, and this is how our OR setup looks. This is about 1 to 1.2 meters away from the surgeon, and this is where the assisting tray is, and this is where our assistant stands. This is the surgeon, and that side is the observer or the surgical assistant. So very quickly, I'll go for a technology overview, and this is the this is the HDR camera, the dynamic camera, which causes image optimization. The good part is that it highlights the important parts or the contours of the surgical area by balancing light, and it mitigates certain reflections. So it's basically optimizing images and highlighting the required curvatures or the required planes of the surgical area. And the good part is it's compatible with all surgical microscopes currently in the arena. There's an optimized high speed image processor. It increases the intensity of the image, and increases the contrast and the sharpness of the image. And of course, we have this giant in the room, which is an enhanced 3D 4K OLED surgical display. And it really gives a very immersive surgical experience, both for the surgeon and the observers and the students and staff around. So, with this, I'll share my surgical journey with the 3D visualization. So, one of the highest unique selling points of the 3D system was that it needed the initial fine focus in high mag, like I'm doing here. We magnify to the maximum extent, and then we fine focus till we actually see the blood flow through these small conjunctival capillaries near the limbus. And once we zoom out, we are sorted. Basically, this acts as a fine focus for both the anterior and the posterior segment. Once we start operating,
You have to unmute yourself, Dr. Apoorva.
I'm not able to hear you, Purva. Slides are seen. The mouse cursor is visible,
No,
but
actually, it is in mute mode. Just unmute yourself. Yeah.
Sir, I've been speaking for the last 5 minutes.
no.
None.
That we heard. That we heard. That we heard.
It's
We
just
can start
happened
with
now.
your first case. You are talking about the capillary blood flow visualization. You can start from there.
Yes, sir, yes, yes. I thought the whole thing was not heard. Yes, sir, yes.
No, no, no.
All right. So this is the first adjustment that we make. This we are set for this. After this, we don't have to keep readjusting, and we don't have to refocus again and again. So power focality is something I want to kind of discuss with this very small snippet of a video. See, I'm cutting very anterior and peripheral, not very peripheral, but yes, it's definitely at a very different plane from the posterior pole, but we can see those membranes are in very sharp focus despite me being at a completely different plane. So that is what is meant by the depth of focus of this system. So the claim is that we can perform surgeries with precision, efficiency, and reduced risk. So let's look at them one by one. There is 5 times extended depth of field, 48% increased magnification, 42% increased depth resolution, and personalized color profiles and temperature panels. So let's look at some of my videos. This is a 27 gauge vitrectomy that I did for a reasonably complex tractional retinal detachment case recently. So this is vitreous hemorrhage along with membranes at the posterior pole. Like I was saying, there is a power focality. You can see different levels. These sclerosed vessels as well as these posterior pole membranes are both in equally sharp focus. I'm using the cutter to kind of create a cleavage. I'm not using much traction. I'm not pulling too much, being careful all the time. I'm just trying to cleave my way with the cutter itself. And once it kind of gets raised a bit, I'm cutting it. Like Dr. Rajiv and Dr. Chakraborty have already shown, these cutters are very high speed and have a low sphere of influence, which allow us to do a very precise surgery. You can see that till now I have not used any forceps. I'm able to get a plane. I believe that the head of the cutter keeps the retina below it down for us, and the mouth of the cutter attacks the membrane that is above it, of course, after we get a good cleavage. So now, by conformal delamination, I'm able to get away all the membranes. And now I change the filter. When I use this green filter, I'm able to see much better these superficial membranes. Then I'm now some blood is getting dispersed, so the view is getting a bit hazy. Probably because of a momentary compromised view, I had this break. And now by conformal delamination, these membranes are coming off. I'm using another 27 gauge instrument in the form of this forceps, ILM forceps, carefully um, peeling this membrane off. So one thing is we tend to do the membrane surgery, and as we are proceeding with the membrane surgery, we forget or we are not concentrating on the oozers that are there. I think it's good advice to take a small break and kind of just see where all it is oozing. Use our diathermy, go in and diathermize the bleeders. Now, unfortunately, we don't have a 27 gauge scissors, so I have made a separate 25 gauge port and used 25 gauge horizontal scissors to do a bimanual surgery. This last bit of membrane is very tough, and you can see the underlying retina is extremely thin. There's a lot of sclerosed vessels over here. So, yeah, so this is the last bit where I'm doing a bimanual surgery. And I'm making sure I take off all the membranes, then I settle the retina with a little bit of PFCL. Thankfully, my macula is clear. There is some blood here, superior and nasally, which is fortunate for me. There's some suboil hemorrhage. but I think overall the result was better. I mean, not that bad considering that there was no suboil hemorrhage at the macula. So this is one more of my surgeries. This is a case where the retina was not very thin. If you can see, this is a very complex TRD. There are a lot of membranes. There is a lot of traction. It's obviously a combined RD, but somehow, luckily, although the vessels are sclerosed out and everything, sometimes we are lucky when the underlying retina has some strength. By that I mean that when we try to peel these membranes away, there's less risk of the retina tearing. So I can demonstrate that in this case for this panel. Basically, when I'm pulling on this membrane with my forceps, any other case with such a complex membrane, I would have expected some distant tears. So this is where my focality comes at handy, because I know that uh, when I'm pulling at one point with my forceps, I have a good focus on other distant areas which are out of that plane, which are in front or behind that plane. So I know the distant effects of my cutting and pulling in one plane. So the visualization of this kind really comes in handy in such cases. So most of us young surgeons, we are a little impatient compared to our seniors, in the sense that I have seen over the months and years that I have been operating, that when I am attacking a certain membrane, um, there's not much mindfulness about what is happening a little distance away. So this kind of visualization helps me see what is happening uh, at a distant, at a distance from the area I'm operating. So here again you can see that I'm cutting here, but there may be distal effects of this action or maneuver I'm doing. So this kind of system really comes in handy at such instances. So this case, like I said, was kind of relatively easy because the underlying retina still had some strength and was not weak and tearing at every excuse. So I had to make only a diathermy and settle the retina. Ultimately, this patient did very well. Or so I thought, but this was a one-eyed patient, and this patient did well for a couple of weeks, and this was a one-eyed patient. I had put oil, but she came back with under oil macular reproliferation. So I went in under oil and did under oil removal of these membranes. I'll just show you. Under the oil, I went in with my forceps. With the oil as the infusion itself, and I peeled this reproliferation at the macula. You can see that again this 3D system comes in handy, because these reflexes that are there, because annoying reflexes that are there because of the oil in situ, they are kind of mitigated by the camera and the image processor. So since I really believe that this surgery has better visualization on this system than the conventional. So you can see I've removed that reproliferation. I did an FAX, removed some more membranes, did an FAX and settled this retina. She's doing well now. This is her only eye. So taking a break from TRD, this is another case where this was a resurgery. In the first surgery, I did it on a conventional microscope. This has nothing to do with the fact that I'm presenting in an Alcon platform or anything. Absolutely not. I'm just thinking aloud, if you wish, and I would like the panel's comments on this case as well. This case is a resurgery I'm doing for a traumatic retinal detachment. This patient is a middle-aged man. In the first surgery, if I can just tell you, there was an incarcerated retina this side. That is on the nasal side, there was incarcerated retina. And somehow I had just made a big retinectomy there and settled the retina. Now, in the redetachment surgery, I removed the oil and I'm removing the suboil fibrosis or the perisilicon membranes that we have. I've injected some TFCL. There are a lot of there was a lot of PVR, like you saw, and I removed those membranes. And I kind of flattened all these folds, and I was doing a laser. Uh, I feel that the DABS provides a better peripheral view because, to my surprise and shock, there was a foreign body in this case, which I discovered only at this point, and it's pretty embedded in the anterior flap of my retinectomy. I had indented in the first surgery. I had checked everywhere. I mean, I didn't expect to find a foreign body, and I didn't look for it, frankly. But here, I feel that this view was not probably possible in the other conventional microscope. So I don't know if I have to attribute it to this superior peripheral visibility, or my presence of mind, or the lack of my presence of mind in the first surgery. But yeah, this patient had a foreign body in the periphery, and I took it out. And then after removing the membranes, you can see that the retina has become more pliant. And in hindsight, I felt that yes, the retina was very sclerotic and atrophic. This is the anterior flap of the retinectomy which I am excising. And then the PFCL went subretinal, so I removed that, and then refilled the PFCL, attached the retina, smoothened all the wrinkles, and did some more retinectomy and attached the retina finally. And this patient is doing okay with this kind of island of retina. So that was about the parfocality, the different planes of resolution, the extended depth of focus. This DAVS also provides high resolution at very, very high magnification as well. So I do use the flat lens for macular surgery many times, but sometimes I do think that I can get away without using it, because this kind of high resolution is available even without the flat lens. And you can see that, especially because I'm using a green filter here, I'm able to do this peeling quite okay, even without the flat lens. So next, we spoke about high mag. I'll show some more videos of high magnification. So this is something I was toying around with in the system. Initially, I felt, okay, the temperature adjustment panels are there. Let's see how it looks. This is a simple RD case I was seeing, and maybe if somebody forces me to say something, I would have said, okay, this green filter, I'm able to see some anterior vitreous better, maybe because of some wavelength tweaking in the panel. So, but then I actually used the color panels which are preset, and they are very convenient in a thumbnail view. You get at the right side of the screen. This was a case of an RD with some subretinal gliosis in the periphery and this kind of macular fold also. And there was some ILM wrinkling here, and since we need very little excuse for peeling the ILM, although I do feel that it was necessary in this case. Anyway, so I started trying an ILM peel, but it was not happening. I used the flexi loop. I was not getting any plane. This is under PFCL because the patient also had RD. So I'm doing under PFCL ILM peeling. So yeah, so then I try to pick it up with the forceps, and then see, these are the ILM folds that are there. Yeah, then I started changing the color profiles. This is the blue profile, and then I changed it to yellow, and then this is the yellow. So then I changed to green. I was not really happy with the green. So these are the various filters. Then I came to these actual thumbnail previews of the filters. So I used yellow first, wasn't very, I used yellow first, wasn't very happy. Then I used green. It wasn't very clear. I stained again. After staining, yes, it was much better visible. Contrast was much better. This is the filter off. See this monochrome filter. I found this really, I mean, something really uh, extraordinary compared to the other filters. Although, you can do it without filters. Honestly, obviously, like everybody else is having, you don't need any fancy filters to do this kind of peeling. But I found this monochrome to give an excellent contrast. One feedback I would want to give is that using these filters make it a little less stereoscopic somehow. I don't know if it's just me. This is without the filter. This is with the yellow filter. This is with the green. Now it's the monochrome. Although the contrast is excellent, the tactile feedback that you're getting using this filter, it seems more two-dimensional. It's not very three-dimensional like you get without the use of filters. Although the contrast is excellent. So maybe in select cases where I'm not able to see the ILM very well or I'm finding difficulty in peeling the ILM, I would resort to using a monochrome filter for such cases. Yeah, so this is that. It was pretty easy to use. And next. Yeah. So then we saw the filters and temperature control on that. So next we have the real-time view of surgical parameters. You can see the infusion pressure. The globe is a little soft, so infusion pressure is only 15. I've kept it that low because I don't want much leakage because it's a SFIL surgery and there's a big main wound here. You can see the cut rate, you can see the vacuum. So all this real-time visual feedback is there from the huge screen itself. You don't have to turn your head, ask the scrub nurse to move away from the panel of the constellation to see what the pressure is. You can just dart your eye towards the corners of this huge screen and you have it. So this is of course an anterior segment surgery that I'm doing. In the newer upgrades, the anterior surgeries also are a breeze. This was a case of a dislocated IOL with bad complex and like explanting that. I'm doing a dumbbell technique of SFIOL where I feed a 60 proline suture uh, through the needle and exteriorize it through the main wound using the nylon forceps. Then I cauterize the outer end with the Yamani cautery and do the same on the other side. And with these sutures, I'm going to thread it through the eyelets of the SFIOLs, both haptics, and I'm going to put in the SFIOL. And the the resolution is fantastic. There's absolutely no lag. I even do my phacos in these combined phaco with surgeries on the ABS. So this is at the end of surgery. After cauterizing and making it bulbous, I put it back into the Hoffman pockets. So, right. Then, of course, you can do surgery in very low lights, like 30% illumination, microscope illumination, or even much lesser. And coming to collaboration, teaching, training, and other educational purposes, obviously it draws in crowds every time we are doing any surgery. Many people who are in the OT who are OT and stand, everyone wears glasses and want to see what's going on because it's such a big screen and it's open for viewing for everyone. And this is our senior most mentor, Dr. Guru Prasad, and the fellow is operating and he's telling him it's very easy to see what a junior colleague is doing because it's out there, just out there. Nobody needs to use a side scope or anything. Our nursing staff are so qualified and so experienced that Even they offer a lot of inputs to trainees, surgical trainees, when they are doing surgeries. So I even did a small study. I'll tell it very quickly in a few seconds. So we compared surgeries performed by fellows on the DABS versus the conventional microscope. We used the ICO Oscar vitrectomy form and asked them. We graded them on how well they do each surgical step, and gave them 1, 2, 3, 4, 5 marks. This is the ICO Oscar form. You can look it up. It's a very comprehensive form for surgical training. So what we saw was that DAVS actually was better compared to conventional microscopy in getting better scores on the Oscar form. And funnily enough, it was for the first year or the junior surgical trainees that it fared better, because the beginners tend to do better if they see better. So that's how we explained it. The senior surgical trainees know more or less about all the surgical steps by then, and it doesn't matter where they do the surgery. But the junior fellows score better when they do it on the DAVS because they're able to visualize better. So usually for our junior surgical trainees, we ask them to start on the 3D system. Ergonomics is a point that they like to mention whenever they tell about DAVS, but it was not true for me. Somehow I used to get a lot of neck pain, which was not there for the conventional type, maybe because we are too used to a particular posture. Then I realized that there is a magical sweet spot which is actually needed. That is, you place the screen at the recommended distance, and the two-third and the head of the surgeon should be at the junction of the upper two-third and lower one-third of the screen. This kind of makes it the exact zen location for better ergonomics and no joint problems. And also the ghosting, image ghosting is better, the focusing is better. So even for the observer, this, I'm a very short person. I'm like just over 5 feet, and this is my friend who is over 6 feet. So when I'm operating, the side scope is not going to be at a very comfortable height for him. So in a conventional microscope, but on the 3D system, he can just sit back, relax, put his feet up and watch what I'm doing, and just come in and assist whenever required. So for my very tall 6 feet and above friends, assisting me is not going to be an issue on the digital system. One more small thing is that for people speckies like us who wear glasses, this clip-on glasses are not good. I don't know if the others agree. It tends to slip down on my nose, so I have circumvented this problem by using the 3D polarized glasses over my glasses. So that's one thing. So this has been my journey from being a junior. I was a junior consultant when I started on the Ingenuity, just 6 months of out of fellowship, and this was a very extreme TRD, which I had attempted. I'm sure, like I cringe when I watch this video. I feel I could have done so many things better. This was a difficult case, admittedly, but many things could have been avoided. And I'm itching to know what senior panelists, Sarunan sir, Mighty sir, and Manisha ma'am have to say about this. I mean, give me pointers on how to manage such cases. You can see that this very thick fibrous tissue is completely adhered to the retina, and the retina around is extremely thin, sclerosed vessels everywhere. Yeah, I'm doing a bimanual surgery. As you'll see over there, like this is a dissection that is going pretty well so far. But then somehow the retina doesn't settle. Like when I remove the membranes also, the retina should become more pliant. It should become a little bullous, at least in the areas where I have removed the membranes. But it was not happening in this case. It was as if the retina was stuck and undergone some intrinsic kind of contracture. It's one of the difficult cases I've done. So after getting some of the membranes out by bimanual, I was lucky to get some out with my forceps. Again, very adherent membranes. Bleeding has started. Now I'm peeling some more very carefully, bit by bit. And now I have a massive tear. I don't know what I was thinking. And then this is an FX that I'm doing. I have settled the retina somewhat. I'm able to do some peripheral laser. This was about 2-3 years ago, I think. Then, of course, there's this dreaded sub-silicone oil blood. I don't know. Sometimes when this happens, I feel what's the point of doing such a extensive membrane dissection when you've given the patient sub-oil blood. I really I'm kind of disillusioned by it. So I would love everybody in this panel to kind of help me circumvent these problems. Although now I'm like diathermizing my oozers as I see them, I'm having them a lot less, but still. So this was my live surgery, my first live surgery on the DAVS in the first ever live surgery conference using the DAVS back in 2019. I did an ERM surgery, and this is the integrated, since the DAVS is an open platform system, the integrated microscope integrated optical, I mean the OCT is there, and it's very good resolution also. You can see that the ERM is very well seen. Here you can see the ERM is causing some microfoveolar traction, and I feel the ERM, it was not a very difficult surgery. It was smooth, it was quick, and after removing the island, I closed it. So I just want to say that my first live surgery was on the DAVS. So um, this is one of my cases from last week that I operated a very complex TRD, and although yes, there is some suboil hemorrhage, the macula is flat, and from here the patient has actually got a foveal contour back, for which I'm deeply grateful. So this is my last slide. We were one of the first consumers of the DAVS. I'm probably the youngest, probably the first woman, I don't know. This ours was the first live surgery conference. This was the first live surgery in my life, and it was on DAVS. It aligns very well with my keen interest in surgical training, and it makes for excellent results. Thank you so much.